Welcome to our video on malignant breast neoplasms. Let's begin. Here's a list of topics we'll discuss for malignant breast neoplasms. Let's start with some general information. Breast cancer is the most common malignancy after skin cancer in women and the second leading cause of cancer-related death in women in the United States. It affects more females than males and is more common in postmenopausal than premenopausal women. The risk of developing malignant breast carcinoma increases with increasing age. Certain races, such as patients of European descent, are at high risk, and African Americans have a high risk of developing triple-negative breast carcinoma. A positive family history of breast cancer, or gynecologic malignancies, also predisposes individuals to develop breast carcinoma. Some genetic predispositions also increase the risk of developing breast cancer, such as carriers of the BRCA1 and BRCA2 gene mutations, or having Li-Fraumeni or Peutz-Jeghers syndrome. Smoking and alcohol consumption also increases the risk of breast cancer. Exposure to chest radiation is another risk factor, particularly if the exposure was during childhood. Other factors include those that increase estrogen exposure. These include early menarche, late menopause, nulliparity, increased age at first birth, lack of breastfeeding, obesity, and hormone replacement therapy. Known protective factors against breast cancer include breastfeeding and exercise. It's important to note that OCPs do not decrease the risk of breast carcinoma. Breast cancer can be classified into non-invasive and invasive types. Non-invasive types include ductal carcinoma in situ, DCIS, and Paget's disease of the nipple. Invasive breast carcinoma includes invasive ductal carcinoma, invasive lobular carcinoma, and inflammatory breast cancer. Let's start by discussing the non-invasive type, starting with ductal carcinoma in situ. Ductal carcinoma in situ, DCIS, refers to the malignant proliferation of ductal epithelial cells without invasion of the stroma. It's more common than lobular carcinoma in situ and has a high invasion potential. It's usually found unilaterally and appears as clustered microcalcifications on mammography. To confirm the diagnosis, a biopsy needs to be done. Here's an image showing the difference between localized DCIS and invasive cancer. Notice how in DCIS, the tumor does not invade the underlying basement membrane and stroma. Here is a histological image of DCIS. We can see here that the tumor is limited to the ducts and does not invade the surrounding stroma. DCIS can be treated conservatively with excision of the microcalcifications with wide margins or radically with mastectomy. Radiation therapy can be added following surgery. Next, we will discuss Paget's disease of the nipple. This is a rare type of breast cancer that involves the skin of the nipple and areola. It appears as an eczematous lesion with scaling, erythema, crusting, and erosions. The lesions are itchy and patients can present with a bloody nipple discharge. Paget's disease of the nipple is most commonly associated with underlying breast cancer such as DCIS or invasive carcinoma. This is because it has been theorized that neoplastic cells of the underlying carcinoma migrate to the surface of the nipple through the mammary ducts, manifesting as Paget's disease of the nipple. Here's an image of a breast of a woman with Paget's disease contributed by Ambos. Note the eczematous, scaly, and erythematous appearance of the nipple and areola. This is a classical presentation of Paget's disease of the nipple. To diagnose it, a full-thickness biopsy, also called a punch biopsy, is performed and will show features of adenocarcinoma with the presence of Paget's cells as well as signs of infiltration. Paget's cells are large cells with clear cytoplasm and are characteristic of this tumor. After confirming the diagnosis, imaging can be done to detect any underlying breast carcinoma. Alright, let's next discuss the invasive breast tumors, starting with invasive ductal carcinoma. Invasive ductal carcinoma refers to the malignant proliferation of ductal epithelial cells along with stromal infiltration. It is the most common malignancy of the breast and is usually unifocal and unilateral. Here's an image that depicts invasive ductal carcinoma. Note that in invasive cancer, the cancer cells infiltrate beyond the wall of the duct. Next, invasive lobular carcinoma. Invasive lobular carcinoma is the malignant proliferation of lobular epithelial cells with stromal infiltration. In contrast to invasive ductal carcinoma, it's usually multifocal and bilateral. It's also considered to be less aggressive than invasive ductal carcinoma. Alright, now let's solve this question. A 43-year-old woman comes to the physician due to an erythematous lesion on her right nipple. She has asthma and uses an inhaler as needed. Physical exam reveals an erythematous, scaly, ulcerated lesion with erosions involving the right nipple and areola. What is likely to be seen on biopsy of this lesion? This patient is presenting with an erythematous, scaly, ulcerated lesion involving the right nipple and areola. This is a classical presentation of Paget's disease of the nipple. On biopsy, intraepithelial adenocarcinoma cells and Paget cells with infiltration of the epidermis will be evident. Remember that Paget's disease of the nipple is most commonly associated with underlying breast cancer such as DCIS or invasive carcinoma. This is due to the migration of neoplastic cells of the underlying carcinoma to the surface of the nipple. Finally, let's discuss inflammatory breast cancer. This is a rare and very aggressive malignant tumor of the breast. It's poorly differentiated and invades the breast and dermal lymphatics. Patients with inflammatory breast cancer have a typical appearance of the breast referred to as peau d'orange, which translates to orange peel. The breast appears edematous and erythematous with indurated skin resembling an orange peel. This occurs due to tumor infiltration and obstruction of dermal lymphatics. The breast is also tender and lymphadenopathy is usually present. Inflammatory breast cancer can be misdiagnosed for mastitis due to similar features between both conditions, only it will be non-responsive to antibiotics. Full thickness biopsy should be performed to confirm the diagnosis. Often, aggressive treatment with mastectomy, chemo, and radiotherapy is required, although the overall prognosis of this type of cancer is poor. Here is a characteristic peau d'orange appearance of a patient with inflammatory breast cancer contributed by AMBOSS. Notice how the breast appears enlarged and erythematous with the breast skin resembling that of an orange peel. A 33-year-old woman comes to the physician for consultation on a contraceptive choice. She was diagnosed with breast cancer a year ago and is undergoing therapy. She is otherwise healthy. She does not smoke or drink alcohol. She is starting to be sexually active again and is looking for the most effective contraceptive method. Which of the following is the best contraceptive choice for this patient? A. Combined oral contraceptive pills. B. Hormonal intrauterine device. C. Barrier contraception. Or D. Copper intrauterine device. Alright, so this 33-year-old woman is requesting an effective contraception method. The most effective and best contraceptive method for this patient with breast cancer is D. Copper intrauterine device. Remember that hormonal contraception is absolutely contraindicated in patients with breast cancer. Instead, copper IUD is the contraceptive method of choice. Options A, combined oral contraceptive pills, and B, hormonal intrauterine device, are both hormonal contraceptive methods and are therefore not suitable for this patient with breast cancer. Option C, barrier contraception, is incorrect because it is considered less effective than copper IUDs. This makes the correct answer D, copper intrauterine device. And that concludes this lecture on breast cancer.